Hello. Today I will be presenting a critical review of repetitive transcranial magnetic stimulation, or RTMS, in the treatment of major depressive disorder. This presentation will examine the physiological mechanisms of depression, the physiological effects of RTMS, the current state of the literature on its efficacy, and the integration of proposed mechanisms of action. Finally, I will highlight limitations in existing knowledge and propose directions for future research. Major depressive disorder, or MDD, is a prevalent psychiatric disorder that often leads to poor quality of life and impaired functioning. Patients who are treated for MDD are commonly treated with pharmacotherapy and psychotherapy, with both having high rates of resistance to treatment. In recent decades, non-invasive brain stimulation techniques, such as RTMS, have emerged as capable intervention for MDD. Understanding the effectiveness of RTMS requires not only a review of clinical outcomes, but also a critical analysis of the neurobiological mechanisms underpinning both the disorder and the stimulation technique. MDD is described by alterations in the frontolimbic circuits. The hyperactivation of limbic regions leads to increased attention and processing of emotional information, with a bias toward negative stimuli. Recent studies in neuroimaging demonstrate hyperactivity in the left dorsolateral prefrontal cortex, or the DLPFC. The DLPFC is primarily responsible for executive functioning, together with overactivity in the amygdala and subgenual anterior cingulate cortex, which can lead to negative effects to functions. At the functional connectivity level, studies have shown that disturbances in the DLPFC limbic communication are prevalent within patients who haven't received medication treatment, which displays that depressive disorder is associated with disruptions in the topological organization of functional brain networks. Further, effective connectivity studies showed that depressed patients exhibit impaired top down regulation from prefrontal to limbic regions, which supports theories of insufficient cognitive control over negative effect. Focusing on the neurochemical and metabolic aspects, depression involves dysregulated monoamine transmission. Regarding MDD, three main neurotransmitters are affected: dopamine, norepinephrine, and serotonins. Another issue which affects structure is hippocampal volume, which is decreased in patients with major depressive disorder, which leads to issues with neuroplasticity. Collectively, these abnormalities produce the persistent low mood, anhedonia, and cognitive impairments characteristic of MDD. RTMS is a non-invasive brain stimulation technique where an electromagnetic coil is placed along the scalp. This coil delivers magnetic pulses that stimulate nerve cells in the region of your brain involved in mood control. Applying RTMS to the DLPFC, physiological effects are dependent on stimulation frequency. 10-HC stimulation is the most commonly utilized protocol for MDD. However, data suggests that 5-HC is also effective. These effects may also induce long-term potentiation and some depressive symptoms, which can be fabricated by workings of glutamatergic and GABAergic plasticity. Significantly, RTMS also moderate dopamine agonists. Recent neuroimaging data provided evidence that dopamine agonists induce significant changes in those frontostacial circuits that process reward and impulse control. By altering both local and network level activity, RTMS has the potential to restore the functional balance of prefrontal limbic connectivity disrupted in MDD. Randomized controlled trials have shown RTMS to be an effective treatment for MDD, especially among anti treatment patients. For example, O'Riordan et al. 2007 described responses rates were significantly high with active TMS compared to sham. Meta-analysis provide further evidence. Berlin et al. 2014 concluded that RTMS wasn't equally effective as an augmentation strategy or as a monotherapy for MD. Nevertheless, variability in outcomes may remain. Some patients may experience improvement, while others may show minimal response. This highlights the need to understand RTMS treatment efficacy on a deeper level. Although evidence supports RTMS efficacy, several limitations must be critically considered. First, heterogeneousness in protocols complicates comparison across studies. Variables such as frequency levels, power levels, treatment lengths, and coil placement may vary widely. Secondly, during active stimulation, sham conditions may be slightly increased, increasing the duration of sham stimulation to the mean duration of sensations felt during active stimulation, which may raise apprehensions about expectation properties. Third, although acute efficacy is established, the durability of effects remains limited. There is the chance of relapse and recurrence if the condition is not maintained well, which could lead to negative long term effects. Finally, mechanistic evidence remains incomplete. While RTMS alters neural activity, the precise causal pathways linking stimulation to symptom remission are not fully understood. Together, these issues highlight that while RTMS is a promising intervention, its clinical utility is constrained by methodological and mechanistic gaps. When examining the proposed mechanisms of action, RTMS appears hypothetically well suited to address the pathophysiology of major depressive disorder. RTMS enhances DLPFC excitability, allowing it to regain top-down control over limbic activity, which in turn alleviates negative mood states. However, there may be challenges which implicate this. Not all patients with DLPFC hypoactivity respond to stimulation. Suggesting additional factors contribute to therapeutic response, studies using neuroimaging show that connectivity responses to RTMS vary across individuals, and symptom relief is not always clearly tied to prefrontal activation. Furthermore, the neurochemical contributions remain unclear. While dopaminergic and glutamatergic modulation are implicated, the relative importance of these systems has yet to be resolved. These inconsistencies reveal the gap between theoretical plausibility and empirical certainty. To address these gaps, further research should focus on four key directions. First, personalized targeting using fMRI guided neuronavigation could optimize coil placement by accounting for individual variability in connectivity. Second, mechanistic studies combining RTMS with neuroimaging and spectroscopy are needed to clarify neurotransmitter specific effects. Third, combining RTMS with established treatments such as cognitive behavioral therapy or pharmacotherapy may yield synergistic benefits. Finally, investigating maintenance protocols and home based devices could improve long term outcomes and accessibility. These approaches would allow RTMS to evolve from a promising but variable treatment to a precision intervention grounded in mechanistic understanding. This will encourage further research and study to occur regarding this subject. In conclusion, major depressive disorder involves dysregulation of frontolimbic circuits, neurotransmitter abnormalities, and impaired neuroplasticity. RTMS exerts physiological effects that plausibly address these abnormalities by modulating cortical excitability and connectivity, with evidence demonstrating moderate but meaningful clinical efficacy. However, Variability in treatment outcomes, methodological challenges, and incomplete mechanistic clarity limit its widespread application. Further research should prioritize personalized protocols, mechanistic integration, and long term efficacy to fully realize the therapeutic potential of RTMS in treating depression. Thank you.